All right. Hi, everyone. Thank you for coming to tonight's Grand Rounds with Dr. Tarshish. If anyone has any questions throughout the talk at all, please just write them in the Q&A box at the bottom of your screens, and then we'll get to them at the end of the talk. So now I'd like to introduce our speaker. Dr. Brocha Tarshish is a board-certified medical geneticist. She completed a preliminary year in internal medicine and then completed a residency in obstetrics and gynecology. After working in obstetrics and gynecology for a short time, she then completed a residency in medical genetics at Emory University. After practicing full-time as a clinical geneticist at the University of Miami for a few years, she began working as a medical director for the laboratory division of eviCore Healthcare. In addition to working for eviCore, she worked part-time as a clinical geneticist for Nicklaus Children's Hospital until her recent move to Atlanta. She has published articles in peer-reviewed journals in the field of medical genetics. And with that, take it away, Dr. Tarshish.
Thank you. So I'm going to talk today about clinical genetics, diagnosis, advances, and current challenges. Let me just advance this. So just a quick outline of the presentation. I'm going to talk for a little bit about some diagnostic testing, the evolution of it, and some advances, chromosomal tests and tests for single gene disorders, a little bit about metabolic disorders and the role of newborn screening, some principles of inborn errors of metabolism in the newborn screening process as it actually practically works, some current and upcoming therapies in genetics, including directed therapies for enzyme deficiencies and different types of gene therapy that have become available or are becoming available. Just to give you an idea, this is all relatively recent. In 1878, Walter Fleming discovered chromosomes, actually was able to visualize them under the microscope. And until 1956, so for some of us in our parents' lifetimes, it was believed that humans had 48 chromosomes. In 1956, scientists deduced that they had only 46. So that allowed in 1959 a discovery to be made that Down syndrome is caused by trisomy 21. And you can see this is like a very old karyotype from the late 1950s, but you don't see bands, it all looks black, but you can see the 3 copies of chromosome 21. In 1968, banding of chromosomes was developed, which permitted definitive assignment of chromosomes. Before that, it was just basically grouped roughly on size. Here, you can also do banding patterns and you can be more sure. So G-banded karyotypes, which have become more increased in resolution over the decades, can detect clinically significant copy number imbalances, like not just whole chromosome aneuploidies or changes, but deletions and duplications, but they need to be a certain size. There's limited resolution, about 5 to 10 million bases, and variable quality, and the interpretation is subjective. For instance, we used to have someone we called the human microarray, who was a fantastic technologist where I trained at Emory, but that was a little bit unusual. In 1982, FISH was developed, which allowed labeling of chromosomes. So not only did that allow small pieces of a chromosome to be labeled, and you could tell if they were missing or extra, but it also allowed speed in diagnosis. FISH will be back in a day or two, which for prenatal diagnosis and other urgent needs for diagnosis, it has been very useful. So cytogenetics technology as it stood until about 15 years ago was karyotype FISH and chromosome paint, which is also using FISH. This is chromosome paint. You can paint the whole chromosome, and that is, aside from being pretty, there were some clinical uses for that, but that's where it stood. Then in around 2005, and it's evolved since then, chromosomal microarrays were developed. This will allow small deletions and duplications to show up. So the process of array CGH, or comparative genomic hybridization, or the microarray, works as follows. Patient and control DNA are labeled and they're applied to the microarray. The patient and control DNA compete to attach or hybridize to the microarray. The microarray scanner measures the fluorescent signals, and the computer software analyzes the data and generates a plot. In other words, you'll take your patient, either a male or a female. Let's say it's a male that you suspect has a small deletion or a duplication that wouldn't be picked up necessarily on karyotype the control patient is another male, and they're competing to hybridize onto this chip. They should if the patient has no missing or extra pieces of a chromosome, they should hybridize to a 1-to-1 ratio. If it's for the 22 pairs of autosomes, you should have exactly 2 copies of every part, let's say of chromosome 1, etc. 1 copy of X and 1 copy of Y. Any tiny part missing or extra means that if it's missing, then it'll hybridize in a 1-to-2 ratio. Extra, it'll hybridize in a 3-to-2 ratio. So a deletion or a duplication. And we can make the probes as dense as we'd like. So obviously the resolution and the detection is much, much greater than it is with karyotype. And we tend to make them denser around important genes that are clinically significant if even a small part of a gene is missing or extra. So it detects very small copy number variants. It also detects small deletions and duplications that are contiguous, microdeletions or microduplication syndromes. It doesn't detect inversions or translocations that are totally balanced. A karyotype can still do that, whereas a microarray cannot, because there's no gain or loss of genetic material. Copy number variants can be identified in 10 to 20% of patients with autism, unexplained intellectual disability, dysmorphic features, and multiple congenital anomalies or birth defects, which is why it's now considered first line for any type of unexplained developmental delay or autism versus the karyotype, which previously was. DNA-based tests are performing for use of single gene disorders. You might be testing 1 gene at once. You might be testing a large number of genes in a panel. You look for gene sequencing for mutations and also for deletion and duplication analysis. Just like a small part of a chromosome can be missing or extra, a small part of a gene can be missing or extra, and this can be clinically significant. And it's got many uses: diagnostic confirmation for someone who's symptomatic, carrier screening, pre-implantation genetic diagnosis once a mutation in the family has been identified, prenatal testing for something other than whole chromosome changes, newborn screening, pre-symptomatic testing for estimating the risk of adult onset hereditary cancer syndromes, Huntington's disease, which is a triplet repeat disorder, but still uses the same technology, and forensic or identity testing also uses this type of technology. So human genome sequencing, back in the graphic on the left shows where we were around when the Human Genome Project was being run. That was in the 1990s. So that was the technology then. You would have genomic DNA, break down the genome into large fragments, insert little clones, put the clones in order, break individual clones into small pieces, generate these thousands of sequence reads and assemble them pretty laboriously into the sequence of clones, and assemble sequences of overlapping clones to establish a reference sequence. Those old pictures of gels that you might find in a textbook, that was from that era. Generating a person's entire genome sequence, which became common around 2016, was actually possible with all of these advances in technology. You'll see expressions like massively parallel sequencing and next generation sequencing. So you have genomic DNA, you break the genome into small pieces. Using a computer to help with a lot of this, you generate millions of sequence reads. These are aligned to establish reference sequences, which we have basically because of the Human Genome Project and other advances in knowing where DNA should be inside a genome, and then deducing the starting sequence and then identifying differences from the reference sequence, which again is known because it's been detected and established. So whole exome sequencing, it was possible before this to do gene panels and single gene disorder testing. Whole exome sequencing, which is looking at the coding portions or exons of all 20 to 25,000 genes, probably closer to 21,000 genes. That was available like starting about 12, 13 years ago on an experimental level. Now in 2011, it became available on a commercial level when Ambry added the clinical diagnostic exome, which was the first lab to do this, to offer exome sequencing as a commercial product, along with medical interpretation for clinical diagnostic purposes. The other labs very quickly followed suit. Whole exome sequencing works in the following way. So in the human genome, there are about 180,000 exons. Exons are the protein coding portions of the human genome. And so this the old central dogma, DNA codes for RNA, every 3 DNA bases gets converted to RNA, which gets converted into an amino acid, which are the building blocks of proteins, which constitute the human being. That is referring to exonic DNA, to exons, the coding portions. And these constitute only about 1% of the human genome, which has trillions of bases. But protein coding regions of the human genome constitute about 85% of the disease-causing mutations. Whole genome sequencing looks at other 99% plus the exons. It contains the exons that are sequenced in whole exome sequencing and the introns or intronic DNA. So introns are the DNA sequences that do not code for amino acid, and they constitute about 99% of all DNA. They were originally called junk DNA because of this, but we now understand that introns have important functions. Introns have sequences that regulate gene expression. Mutations in introns are responsible for about 15% of single gene genetic disorders, while mutations in exons are responsible for 85%. So while whole exome sequencing is a more efficient test, performing whole genome sequencing still significantly increases detection yield. And then there's the interpretation. You have all of this data. It's massively parallel. It's all generated. How do you interpret it? That's actually where most of the cost of whole genome sequencing and whole exome sequencing comes from. And whole genome sequence of every person, even a healthy person, an apparently healthy person, will reveal 60 to 100 changes that are predicted to be loss of function mutations, 500 to 800 missense mutations, which can vary from completely benign to likely pathogenic or disease causing, false positives, false negatives, and some results we just can't interpret now. And the interpretation of the data will change over time, and I've seen it change over time. And just with all of this diagnostic testing, I still want to mention that family history is still the most available and least expensive genetic test and one of the most useful. So it's important to encourage and empower individuals, family members, your patients to assume responsibility for establishing and maintaining their family history. And there's a website you can do that at. Then moving on to metabolic disorders and the role of newborn screening. Metabolic diseases in general, it's a large class of genetic diseases involving disorders of metabolism. The majority are due to defects of single genes that code for enzymes that facilitate the conversion of various substrates into products. Newborn screening helps identify patients before they get sick. Treatment often includes special diets and sometimes medications, and some common examples are PKU or phenylketonuria, which was the first one and the original reason for newborn screening, fatty acid oxidation defects, and galactosemia. And I also want to emphasize that we do test for inborn errors of metabolism of all types on newborn screening, but we also test for endocrine disorders like hypothyroidism and others. We test for lung disorders like cystic fibrosis. We test for hematologic disorders like sickle cell anemia and others. And the geneticist really only handles the inborn errors. When to consider a metabolic disorder, a catastrophic neonatal presentation, but this is not at the moment of birth. This is typically days to weeks after birth. Biochemical disturbances, liver disease or dysfunction, neurologic features, myopathy or cardiomyopathy, or even sometimes it can show up as signs of a storage disease. Typically, these symptoms occur in a child who really appears healthy right at birth. So a metabolic disorder, you have, in general, the classic or platonic ideal of a metabolic disorder is you have precursors, you have a substrate, the X is because you're missing an enzyme to metabolize it. You don't get the product, you get backup of the substrate. You can use some alternative pathways sometimes to metabolize this, which we'll talk about, but because you don't have the product, you also don't get the later products. So the classic example, and one that was probably has been understood well for the longest time, is phenylketonuria or PKU. So phenylalanine, which comes from natural proteins, is the substrate. It's coming from dietary protein. Phenylalanine hydroxylase is the missing enzyme or the deficient enzyme. Tyrosine should be made from phenylalanine hydroxylase, but it's not because in patients with PKU, because they can't convert phenylalanine. The phenylalanine backs up. It's incredibly neurotoxic. Tyrosine doesn't get made. So that goes from being a non-essential amino acid to that the body can make from phenylalanine to an essential one that in these kids, the body cannot make, and they also don't make enough melanin. So in this case, this is a picture of someone who was born before newborn screening, where after newborn screening was developed, they sort of went around to all of the institutions that had intellectually disabled individuals and tested them, and something like 1 or 2% actually had untreated PKU. And you notice that his hair and skin is very light. Maybe that's familial, but maybe it's also untreated PKU. So because a child with PKU lacks the normally functioning enzyme that's necessary to break down phenylalanine, it accumulates in the blood and body tissues, prevents normal brain development, and results in intellectual disability. So in general, high phenylalanine foods are foods with a lot of natural proteins, including bread, which is made from wheat, which has gluten, and very often eggs. Low phenylalanine foods are most vegetables. I don't really think corn and broccoli should be there, but most fruit. Sugars, aspartame, the artificial sweetener, is a huge dose of phenylalanine and aspartame together, and aspartic acid together. So that's worse than natural proteins for them. So they have special formula with phenylalanine taken out and tyrosine added, and they get special breads, cookies, and crackers made from wheat that has the gluten portion taken out and has other gums and other substances added to help it stick together. Newborn screening is a public health program that's really aimed at identification of conditions for which early intervention can prevent mortality, morbidity, and disabilities. If there's no intervention, we don't test for it on a large scale. It's performed by analysis of diagnostic markers and blood spots that are collected on filter paper at birth, which is this little baby's getting its heel pricked and it's put on a filter paper. The extent of the program is chosen and upgraded by each state independently, but since about 2005, it's been standardized to at least do a couple dozen disorders in every state. So some current and upcoming therapies in genetics. We have directed therapies for enzyme deficiencies, which I'm going to talk about a little bit, and gene therapy of all types. Including some therapies that are arguably don't exactly fall under gene therapy, like some of the new therapies for cystic fibrosis, but I'm kind of grouping it there anyway. So directed therapies for enzyme deficiencies. We have enzyme replacement therapy for lysosomal storage disorders, or LSDs, which are a group of disorders that where an individual is missing an enzyme, and they're typically recessive disorders. A couple of them are X-linked recessive. They are unable to, because they don't have this enzyme, different cellular waste products build up and cause different symptoms. Some are mostly physical, some are mostly neurologic, some are a combination. Substrate reduction therapy, which can also be used in addition to or to replace enzyme replacement therapy, pharmacological chaperones, enzyme substitution therapy, and coenzymes. So enzyme replacement therapy the first one was approved for Gaucher in the late 90s, and that was the first of its class. This missing enzyme can actually be infused, and it's incredibly expensive, but it's possible to give it, which was a game changer. And now it exists for Gaucher, Fabry, Pompe, mucopolysaccharidosis 1, 2, and 6, and some others that are being developed that I didn't include, but these have been around the longest. And when I say the longest, Gaucher has been around for a little over 20 years, and the other ones have come in the 2000 and the 2010s. It does not correct the underlying genetic defect. It's not gene therapy, but it does increase the blood concentration of the enzyme, so their bodies can get rid of the waste product. It has to be given regularly by IV infusions, usually every 2 weeks, and it takes a couple of hours. There's also the risk of hypersensitivity reactions. So it's inconvenient, and it tends to have to happen in a hospital-based setting. After a while, some people we put on home-based infusions, and it doesn't cross the blood-brain barrier if it's given through IV, but there's some success in crossing the blood-brain barrier if it's given intrathecally. So lysosomal storage disorders or other storage disorders that mostly have neurologic manifestations, we don't really have enzyme replacement therapy for, because it would not be as useful. Even given intrathecally, it's not fully successful in general. And the reason why we do treat Hunter disease with enzyme replacement therapy, even though it has a lot of MPS 2 and MPS 1, even though it has a lot of neurologic manifestations, is because there are also physical manifestations. And for MPS 1, Hurler or Hurler-Scheid, there's different variations in how much the patients are neurologically affected versus physically affected. So it's worthwhile, but it's not perfect. Substrate reduction therapy, like Serdelga and Zavesca, are available for Gaucher disease. We think that it works by inhibiting the enzyme glucosylceramide synthase, which is the enzyme that's involved in the production of glucose cerebroside. People with Gaucher are missing glucose cerebrosidase, so glucose cerebroside accumulates abnormally. So we think that it inhibits an enzyme, and that helps the lack of glucose cerebrosidase be less, affect them less. So it's given PO. I've seen patients come off of enzyme replacement therapy for Gaucher with it. Some people will use it to sort of supplement enzyme replacement therapy, but it's also very good if there's ever, first of all, like you have to do a lot of tests, and many Gaucher patients aren't candidates. They need a lot of labs first. They need to sort of pass certain tests in order for this to work, to know that it's going to work for them in terms of lab results and just other concerns. But if they can go off of enzyme replacement therapy, that's incredible. Even if it can improve their response, because like they're getting 2 therapies instead of 1, that's also incredible. Pharmacological chaperones are another class of medication. So we have Galafold for Fabry disease. And this is for Fabry patients. Fabry is an X-linked disorder that is also a missing enzyme, and it causes a lot of physical manifestations, decreased sweating, just like severe joint pain, and eventually end organ dysfunction, especially in affected males, although affected females, carrier females can also be affected. For Fabry patients whose mutation causes a misfolding of the enzyme that would otherwise be functional, which is about 35 to 50% of Fabry patients. So it's not that they don't make enzyme, it's that their mutation stops it from the protein, which is kind of formulated normally from folding properly. So this giving Galafold, it binds to faulty alpha galactosidase A, and it shifts the folding behavior towards the proper conformation. Isn't curative, but it also improves the response to Fabry disease. It's given PO. It can get people off of infusions as well, or at least it can supplement infusions. Enzyme substitution therapy is a relatively new class of medication. The main example is pegvaliase, which is also called Palynziq or PegPal. It's a pegylated to make it last longer in the body, derivative of the enzyme phenylalanine ammonium lyase or PAL. It can metabolize phenylalanine in the blood, and it's technically not considered enzyme replacement therapy because it's not replacing phenylalanine hydroxylase. It's substituting a different enzyme with a similar mechanism of action that metabolizes phenylalanine, and it's given subcutaneously. So it's not given every couple of weeks as an infusion over hours. It can be given subcutaneously every day to help patients, and this has been very helpful. And we've had patients go on normal diets where they can have as much natural protein as they want because pegvaliase is so effective. For pegvaliase, there was BH4 or Kuvan, which is a cofactor of phenylalanine hydroxylase. It can increase the efficiency of residual phenylalanine hydroxylase activity in patients with PKU and increased phenylalanine tolerance. In general, this always worked best in people who had at least a little bit of residual enzyme activity. Even people with total deficiency less than 1%, sometimes they could increase their protein tolerance slightly, but it was never a large response unless they had some available enzyme. But that was available. It's given orally. It's a powder. It can be mixed in drinks, and it's been available for a lot longer than pegvaliase. There's also exon skipping for DMD treatment, Duchenne muscular dystrophy. So Exondys 51 was approved by the FDA in 2016. This induces skipping of exon 51 during pre-mRNA splicing, which corrects the DMD open frame. I'm going to have diagram on the next slide because it's hard to picture. This has been proven to restore some dystrophin in muscle and to increase ambulation in affected patients. So the point, it's not going to ever cure Duchenne, but the point is to make the Duchenne less severe, a little bit more like a Becker muscular dystrophy. So exon skipping works as follows, and the graphic is just so cool because you can really see it. So with the mutations in Duchenne are typically deletions and duplications, not point mutations in the sequence. Especially deletions are really common, especially around the hot spot around exons 48 to 52. It's a really common site to have deletions of one or more exons. So because they have this deletion in a healthy person who has a normal DMD gene, you get this pre-mRNA product. This becomes mature mRNA, and because everything's fitting together, you get dystrophin. You get a normal amount of the dystrophin or the protein product of the DMD gene, of the dystrophin gene. With a DMD patient, again, this is a real hot spot for deletions and duplications. Let's say 49 and 50 are missing. So when you put this together, it doesn't get you don't get a normal, you get an out of frame change. You don't get a normal mature mRNA that can make normal protein. You might even make protein up to here, but because there's a premature stop codon that's going to be coded for because of this abnormal product, you'll actually, even the protein you make will be subject to nonsense mediated decay, and you basically get nothing. This is Duchenne. No dystrophin is produced. With exondys 51, this takes out exon 51 out of the reading frame. 48 and 52 together, reading frame is restored, and you don't get a full amount of dystrophin, but you get a little bit of a shortened but somewhat functional amount of dystrophin. This hasn't been as effective as we'd like. It definitely doesn't cure DMD, but at least there seems to be some increase in ambulation. Gene modulators are another class. You'll see it in CF for people with mutations in CFTR causing cystic fibrosis. So it targets the underlying defect in the CFTR protein. There are two main types of CFTR modulators that are currently used: potentiators and correctors, and they're also used in combination, which I'll get to. So a gene potentiator is ivacaftor, for instance. That was the first one. We have some next generation ones. It's for gating and conduction mutations in CFTR. So it works on residual function. It also works on residual function and splice mutations where not enough normal protein is present, but there's some. Some CFTR protein reaches the surface of the cell. They do have, it's not like they don't make the protein at all. But there's either not enough protein that's reaching the cell surface for the ion channels to function properly, or the protein doesn't allow enough chloride to flow through. So holding the gate, this potentiator holds the gate on the CFTR protein open to allow more chloride to flow through and thus reduce the symptoms of CF. A gene corrector is another class. Lumacaftor is another example. It helps the CFTR protein form the right 3D shape, kind of like Galafold with Fabry, so that it can move to the cell surface and stay there longer. For instance, the delta F508, which is a really common mutation, results in an abnormal CFTR protein that can't reach the cell membrane to transport ions. So the protein actually is made, but it can't reach the cell membrane. So even with correctors, only some of the CFTR protein reaches the cell surface. And also the proteins that do reach the cell surface don't open enough to allow chloride to pass out of the cell. So if you combine a corrector and a potentiator, you hold the gate on the CFTR protein open, enough chloride can then flow through to reduce CF symptoms, and more flows through. There's the first generation of this Lumacaftor ivacaftor combination was called Orkambi, and now after that there was Syndenko, and it was always for people with 2 copies of the delta F508 mutation, which is the most common mutation in this country of cystic fibrosis patients, but not everyone has both of those have both of their mutations as delta F508. But just to give a graphic of that, here's the cell surface. Here's the CFTR protein. We're trying to get a functioning chloride ion channel. Here are chloride ions, and this is inside the cell. So without Orkambi, ivacaftor is holding the gate open. It's holding the ion channel open to allow more chloride ions to escape. And lumacaftor is bringing more of these CFTR proteins from the inside of the cell to the cell surface. Newer corrector potentiator combinations have wider use, like trifacta, which combines some of these next generation correctors and potentiators. And it's a triple combination therapy that can be used to treat people with CF who have at least one copy of the Delta F508, regardless of their second mutation, which is over 90% of CF patients in the US. Gene therapy, as a general rule, it delivers functional copies of the defective gene into the body, or it helps the body repair mutations in the gene. So examples that have come up recently in the last few years, Luxturna for RPE65 related Leber congenital amaurosis, which is a progressive retinal disease that leads to blindness. This gene therapy, Luxturna, delivers a normal copy of the RPE65 gene directly to retinal cells. Zolgensma for spinal muscular atrophy, which has been in the news, and then there was also a few years ago that became a big story. It replaces the function of the missing or non-working SMN1 gene with a new working copy of the gene. So these are the four major categories of gene therapy. How do we fix genes? So there's gene addition, where genes are added via a viral vector. This is probably the most well-known the most well-known form of gene therapy, and it's probably the most in the news. Gene silencing, which is a little less common, but they're working on some of these therapies. Gene modified cell treatments, like gene therapy, cell therapies like CAR T therapies, and there's a new one that just got approved, and we'll talk about it. And gene editing, which is CRISPR, Cas9, zinc fingers, that type of thing. So, I mean, the main problem with gene therapy is that it costs over $1 billion to develop. There's a small market, and it's replacing, if it's a one-time treatment, it's replacing a lifetime of standard treatment, but you have to prove that it's going to last and that it's going to be cost effective. And then how do we deliver gene therapy? We can do it in vivo, where it's actually delivered in real time. Local delivery would be Luxturna, where it's injected into the back of the eye. Systemic delivery is Zolgensma, where they get an infusion right there. And then there's ex vivo, where the gene therapy is applied to cells outside of the body. Basically, the body's induced to make more hematopoietic stem cells. They're taken out, they're treated with the medication, and they're put back in. And that examples of that are Zynteglo and Skysona, which was just approved. And when we talk about viral vectors, just without going into too many details, there are differences between them, and those differences are exploited for the different types of gene therapy. So there's RNA, there's retroviral using RNA, and lentiviral also using RNA vectors, and these cause persistent gene transfer in transduced tissues. So the advantage is that it can be a lasting effect, or is more likely to be a lasting effect. And for certain targets, it needs to be this. The disadvantage is that you're changing you're causing gene transfer. You can cause an oncogene to sort of become activated. So there's always the concern of cancer, especially hematologic malignancies. Adenoviral vectors were used, especially in the past, in the early days of gene therapy. There is a large immune response to the vector, but they don't integrate well into the genome the way lentiviral or retroviral vectors do. They don't have as much long-term expression for this reason. They're highly effective in transducing different tissues throughout the body, but they can cause a massive immune response. So more recently, we've been using for certain similar properties adeno-associated viruses, which seem to be safer than adenoviral viruses. These are poorly integrated into the genome. they actually can sometimes induce long-term expression. They elicit few inflammatory responses, and in general, they are not pathogenic inflammatory responses. They cause pretty mild disease. So some new therapies that have recently been approved that use these technologies, beta thalassemia treatment, gene therapy, Zynteglo, which was just approved a couple months ago. It's a lentiviral vector plus a modified beta thal gene. It caused beta thalassemia it's about 1 in 100,000. Its prevalence varies. It seems to be increasing. It's common in certain ethnic groups. They have a shortened lifespan, and basically they have just this chronic anemia, hemolytic anemias. They become transfusion dependent just because they're so anemic. They get iron overload from the transfusions, and this causes end organ damage, cardiac cirrhosis, endocrinopathies. Everything you've heard about just being about chronic transfusion dependence or iron overload happens to these people. So with this, it was in phase 3. They had 89% transfusion dependence after 2 years, over 2 years after treatment. Iron stores and chelation therapies, which would be the standard of care along with the transfusions, does not become as necessary or isn't necessary anymore. There's no evidence of, even though it's using a lentiviral vector, there's no evidence that there is insertional mutagenesis. Yeah, it's being inserted into the DNA, but nobody's gotten cancer from it. It's expensive. It's 1 to 2 million plus the hospital stay. But there are probably up to 1,000 patients who have this transfusion dependent beta thal, and this could be curative. And over a lifetime, this may save money. Certainly it'll lengthen their life and increase their quality of life. But we also have some hard challenges, some hard lessons and challenges within the industry. There's the safety of viral vectors, which again was a bigger issue with the adenovirus vectors, but they cause anaphylaxis. And after a patient named Jesse Gelsinger died in the US trying out gene therapy for his OTC, basically probably due to a massive immune response that caused severe liver failure. There was a moratorium for many years on this, and we just had to go back to the drawing board. And that's why safer, like adeno-associated viruses, other safer vectors were developed. And then there's lentiviral vectors, which are still used. There's still the concern of insertional oncogenesis. And then there's the durability of response. And that came up recently with a gene therapy called Roctavian, where you get a response, but it doesn't last as long as you like. There's the cost of development, and there's financial risks. So Roctavian is a hemophilia A gene therapy. Hemophilia A incidence is about 1 in almost 6,000 males. Prevalence is about 12 in 100,000. It causes spontaneous joint bleeds, deep muscle bleeds, bleeding, pain, swelling from minor injuries. They become dependent on factor VIII infusions. They get severe response to like minor traumas. So this gene therapy for hemophilia A was developed a few years ago. And in 2020, it came up for FDA approval. And it seemed initially it worked great. Factor VIII expression, which is in severe hemophilia A, 0 to 1%, it went up to 63%. They actually, this is more than enough to reduce bleeds, but the effect wasn't durable. So with hemophilia A, it's a question of annualized bleeding rates, and they have phase 3 data that it's helping, but the level of factor VIII activity level compared to controls went down to like 5% within a couple of years. And there was a question over many years, is it going to go down to 0%? Are they going to need to go back to factor VIII infusions? So to factor VIII, to needing factor VIII treatments. So the FDA decision in 2020 was not to approve. It's going to come up again in the next year, and they think they can increase the durability. But or the other option is giving a second or a third dose, but how does that impact the price? So the pricing, if it's a one-time curative medication, then it might be justified. If it's going to need to be used chronically, it might not be approved. And yeah, the expression of this definitely declines over time, and they just what's going to follow is bleeding. So this is like they showed that it was the F8 activity level was about a little over 5% at 1 year, and it was decreasing over time. There's a new treatment that's actually supposed to be up for FDA review this month, for X-linked cerebral, for cerebral adrenal leukodystrophy, also known as X-linked adrenal leukodystrophy, which was the disease that Lorenzo had in Lorenzo's oil. This is lenti-D or Skysona. It's a lentiviral vector, and it's also the ABCD1 gene that's mutated in these boys. In neurologic symptoms stabilized in 87 to 97%. 3 patients developed myelodysplastic syndrome out of 55. So they know that this is related to the insertional mutagenesis of the lentiviral vector. Administrative costs are expensive. So the drug itself is a couple million. The administration is a couple $100,000, even though they're taking out stem cells, treating them, and then infusing them back. And stem cell transplant is still considered first-line treatment, and that's been around, but not all boys with this will find a match. X-linked ALD is caused by, it's an X-linked disorder caused by mutations in the ABCD1 gene. It causes toxic accumulation of very long-chain fatty acids, which causes myelin disruption. Its incidence is about 1 in 5,000 to 1 in 17,000 in the US. Newborn screening is not fully adapted for it, just because there isn't always a great treatment, and some states are slow to take it up. Stem cell treatments, with all their risks, are the best cure up until this, and still considered first line, but it's not always available for all patients. Once it causes normal their development's normal at first, and then there's a rapid progressive neurologic decline that just causes, they just completely lose neurologic function. The rule of thumb for stem cell treatments for this disorder is that once they're past a certain point, once there are MRI changes, once there are neurologic changes, they actually are no longer candidates that are severe enough. They're no longer candidates for the stem cell treatment because the risks outweigh the benefits, and once the neurons are gone, they're not going to regenerate. And the same goes for Skysona or lenti-D. Once they have that neurologic dysfunction, they're also not candidates for this. Hemophilia B gene therapy, actually, unlike the hemophilia A therapy, this seems to be working. This is on Tronidade. It's fixing, it's an adeno-associated vector and it's fixing the F9 gene. It's a systemic infusion. They had a sustained response that was actually very strong. 96% were able to stop taking their prophylactic factor 9, which is the factor that they don't make, unlike hemophilia A where it's factor 8. There were 2 non-responders. One it didn't work, and the other one had only gotten a partial dose. So that was probably it. But this is sustained at 18 months. It's almost as good as 6 months. One patient died and another developed carcinoma, but neither was related to the treatment. This is less common than hemophilia A, but it's really hard to treat. It's 1 in 20,000 males. It causes spontaneous bleeds into joints and soft tissues, disabling synovitis, muscle atrophy, intracranial hemorrhage. If anything, it's probably worse than hemophilia A. There's also a new therapy for DEB, or dystrophic epidermolysis bullosa. That's really exciting. It's called VYJUVEK. It's in phase 3 randomized clinical trials. It works and it's safe. It's actually, this viral vector is a little bit different. It's HSV1, probably because it seems to have such an affinity to skin, and they're fixing the COL7A1 gene. It's delivered via a topical gel. It does not go in the bloodstream. The target is keratinocytes and keratinocytes and fibroblasts, and the product is COL7A1 to have a functional protein, and so that the epidermis and dermis can stay together and have integrity instead of separating. They found that it can only be applied to skin that has blisters already, but 67% of wounds healed 100 days sooner than they would have on their own. But it's multi-dosed. It needs to be given, because it's given topically and because it's only given when the skin is wounded, and it's really just, it's not targeting, it's all topical, and it's not targeting any progenitor cells. Skin's going to turn over, and you're going to need another dose. Not as expensive as the others, but 100,000 to 200,000 per treatment. DEB is a devastating disease. It causes severe skin fragility and blistering with minimal or almost no trauma. There can be involvement in the mouth, esophagus, cornea, which can lead to blindness, severe skin infections, which they can die from. They also, 90% develop aggressive squamous cell carcinoma that tends to metastasize. And up until now, treatment has been just avoiding trauma and palliative, and they have a very shortened life. I know someone whose niece died at 7 from it. So this is a very useful therapy, but it's going to cost money over a lifetime. In the future, we might be looking at gene therapy without viral vectors, like CRISPR and Cas9 in vivo gene editing for, there's a trial going on now for thyroid amyloidosis. This is a disorder that causes buildup of misfolded transthyretin protein, which increases the amyloid in tissues. It causes tissue dysfunction. It can cause some end organ damage, but really the disease causes severe neuropathy, including dementia and peripheral neuropathy, and it causes early death in most cases. This is targeting a protein that's normally produced in the liver, and when it has normal function, this is a landmark clinical trial that doesn't use viral vectors. It's only the first or the second one using CRISPR or Cas9. It's using a lipid nanoparticle instead of viral vectors, and mRNA and Cas9 protein together. And they were actually able to reduce the serum TTR concentration by 87% in the high dose group. And of 6 patients, all showed reduced TTR protein post CRISPR Cas9 treatment. It's another trial that's been going on. So CRISPR and Cas9, CRISPR it was a big genetic story of 2015. It stands for clustered regularly interspaced short palindromic repeats, which is a family of DNA sequences that's found in the genomes of prokaryotic organisms, mostly bacteria. Cas9 is CRISPR-associated protein 9, and it's the enzyme that uses CRISPR sequences as a guide to recognize and cleave specific strands of DNA that are complementary to the CRISPR sequence. So the two together are what you use for gene editing, at least in theory. Another trial was started in March of 2020, and they've actually resulted it. They're in the midst of resulting it. It was the world's first clinical trial using CRISPR genome editing medicine in humans. It's called Edit 101. It was testing the ability of CRISPR and Cas9 gene editing techniques to remove mutations in CEP290 that cause LCA10, which is another hereditary progressive retinal disorder. There's no treatment available for the disease. It's a leading cause of retinal blindness in childhood. They started out testing it in adults. The safety data was fine, it was great. There was positive preliminary data. A pediatric patient was dosed earlier this year, and data released 3 days ago showed that 3 out of 14 experienced clinically meaningful improvements in best corrected visual acuity, and it was a safe medication. So that's as far as we're going with CRISPR and gene therapy, but there's more coming down the pike. Here are some great therapies, some great resources, and the American Society of Gene and Cell Therapy is a great website with some great videos. And then I'm going to end this with a quote from Einstein that you can either believe that everything's a miracle or nothing is. I believe that these are miracles. Thank you.
Thank you so much for speaking tonight. That was really fascinating and very informative. If anyone has any questions, please feel free to just type them into the Q&A box at the bottom of your screens. And we do have a question here, actually. Does exome sequencing show every gene mutation?
So it should, I mean, there are limits in the technology. The mutations that it shows with any degree of, I'm actually glad someone asked that because I didn't mention it in my talk. It shows sequence mutations, like sort of the misspelled words, and it doesn't show small deletions or duplications in the gene with any with you can't rely on it for that. It's not validated for that. We actually can't use it. And sometimes we'll talk about the advantage of like a gene panel. If you think you know like sort of what gene or group of genes might be used, that exome can't pick up, and it's mostly those deletions and duplications. Early exomes actually probably missed sequencing variants too, but then they had this, you know, they made sure it was like kind of blast sequencing covered 10 times or more. So that sort of took care of that problem. It can actually pick up, not again in a really dependable way, but it actually very often will pick up copy number variants like chromosomal disorders, deletions or duplications will come up, will be detected on a whole exome sequencing. But again, you can't count on it. So yeah, those are the mutations you can't pick up, deletion and duplication mutations.
Okay.
And again, this is looking at nuclear DNA. So you have to add on mitochondrial DNA. If you don't add it on, you're missing the mitochondrial plasmid has a couple dozen genes. You're missing those if you just do nuclear DNA.
Okay, got it. So thank you so much for your talk tonight. That was really interesting and I learned a lot personally. And thank you to everyone for joining us tonight, and have a good night.
Thank you.